So look at the skeleton. If he had a hawk-like acromion, it would be a hook. I'd be catching it.
It works now.
Okay. And the same thing with near the ear. He rolls his hand internally rotating and near his ear. That would also catch it.
Pressure on the scapula while we're doing that. Bates had said something. We can just have them do that.
You don't have to put any pressure.
Yeah.
That might make it better, but we didn't. It's totally fine.
It was in phase.
Yeah. It might be about. It might add a little something, but if they've got hurt us, we don't have to. Yeah.
They've got a thing that they're probably going to see.
Yeah.
I feel
He
it.
knows. Yeah.
I feel it, and like I can only bring mom about halfway.
All right. Did we finish shoulder? Are we on elbow?
Yep.
Okay. For elbow, so you feel all along the elbow. The medial and lateral epicondyles are the widest part of the humerus down in the elbow joint. And you feel that, I just naturally start feeling for crepitus all in the same, but whatever the checklist says. Feel the olecranon, which is the prominence, the actual point of the elbow. And then at the end of it, if you had a bursa, it would be there too. So you'd be feeling that. For carrying angle, which is part of the inspection, you have the patient just stand. And we're looking,
How do you
and
evaluate?
we work. It's just if he instead had been like this or some deformity. This is normally like this. So it's normally a valgus. That's the natural position. We were comparing a number of students. Dr. Smith was saying and Dr. Waldeck that men tend to be straighter. We found some variations amongst the group though. Some women were straighter. So, but anyway, but it should be symmetrical and it should be somewhat valgus. Okay.
So then you do your range of motion, flexion, extension.
Okay, so passive range of motion, I do it. Active range of motion, the patient does it. So there's basically just flexion, extension. For pronation and supination, you should help by holding the humerus. Now go ahead and turn your head in and out, because otherwise he's rotating at the shoulder. So try to hold it.
And then it's just the strength testing.
And strength testing, you could do both arms together, flexion, extension. If we have you do pronation and supination, you have to do those separate. So don't let me move you that way, don't let me move you this way. I'm twisting him both ways.
You're going to hold the humerus for that too?
I actually, if you have it bent, it's actually fine.
Okay.
If you need to though, my other hand is free, I could do that, if I felt he was doing that.
And then now hands and wrists.
Okay, hands and wrists, so just remember, wrist was a problem, remember that I mentioned that you have to hold the forearm and then push up against me and then push down against me. If I don't, and I have him push up against me, he's moving other joints. Okay, so be sure and do that. For the passive range of motion, he's moving this direction, that direction, and we would do it with him. Radial deviation is this direction, ulnar is this direction. So, that way, that way, good.
And how do you find the snuff box?
The snuff box. Okay, so you have to do it with the patient. Have them extend their thumb backwards. Remember, that's extension. That opens up the triangle. That's the snuff box. And that would also, the next thing you palpate is on the radial side is the first dorsal compartment, and that's where the abductor pollicis longus is and the extensor pollicis brevis. You could feel two tendons there, and this is the extensor pollicis longus. Okay. So you've got two bullet points on that. And this is where when they do de Quervain's, they're pulling that first dorsal compartment over on the styloid process.
So when you palpate, you're palpating for those tendons?
So first the snuff box, so I ask you to do this. So do that. If you extend more, you'll get a better one. Can you bend up that way? Okay, really bend that there. Now it's right here. Okay, it's right there. This is your first dorsal compartment. And this is your extensor pollicis longus.
So you're feeling the tendons, you're not feeling...
No, first the snuff box is in here, because I'm feeling the navicular bone that way, and the trapezius, if you fractured them. And then this is where those tendons are. And they're both bullets on there, so make sure you do both, because they're two different bullets. Okay. What else is special on there?
Yeah, so the adductor pollicis longus and extensor.
That's that first dorsal compartment.
Ulnar aspect of the wrist.
Okay, ulnar aspects on the other side, on the pinky side.
So
then you do the passive range of motion, active range of motion, and then you do strength testing.
Okay, and just remember to stabilize the forearm.
And then the next ones are your special tests, so your Tinel sign.
Okay, so Tinel's sign, I tap, the median nerve's running all the way into the hand. We're trying to get it where it's sort of the most closest to the surface. So right here is a really good place. Do you feel anything at all? Sometimes people just feel, yeah, right in the middle. And sometimes people just,
really,
you might feel lightly a little bit of a nerve impulse sensation there. Maybe not hard, but if the person has like lightning feeling or pain, that's indicative that their carpal tunnel is probably squeezing their nerve. Okay, then Phelan's, you have them do this, so they're in this position.
from thumb to first.
Okay, so you want to be trying to bring your elbow. Your wrist hurts. Oh, your wrists are bad. Okay, so that could be a positive test. Try to have the patient be as horizontal as possible. Okay, and then you would have them hold it for a minute or until they experience discomfort. Yeah, get numb. Because you do so much keyboarding and mouse work, we all have a little bit of carpal tunnel probably. Yeah. Dequervain. So Finkelstein's, we could do it for them or they could do it. So have them hold their thumbs, they could do both sides at once, and just ulnar deviation is what it is. And it brings that first dorsal compartment over the bone. I don't have pain, but a lot of people express pain. Now if I wanted to do it for the patient, I have you hold your thumb, relax, and I just do it.
And you're looking for more pain on one side than the other, right?
Yeah, well, and I would definitely check the side that they said they had pain.
And then
Gamekeeper's thumb.
thumb, ulnar.
Oh, the ulnar, okay. So this is the radial side of the thumb. This is the ulnar side of the thumb. If the patient had an accident like we were saying, snowboarding, ski pole, or the gamekeeper, which was from pulling chicken heads fowl off, that's how that would happen, it would tear this ligament. That's why it's called gamekeeper's thumb. It was named after that. The ligament is right here. It's right here. It's holding the base of the phalanx of the thumb, the proximal phalanx, to the metacarpal. So you have to stabilize the metacarpal, and I'm bending out.
So that's how you check that.
That's how you check it. Do you see what I'm doing? So I'm stabilizing here, and I'm bending right there. And if he really moved, and if it really hurt, I would worry that he tore that ligament.
Gotcha.
Okay.
But why is it says ulnar collateral ligament?
Because it's on the ulnar side of the thumb.
Okay.
Ulnar side. It's the ulnar collateral ligament of the thumb. Of the thumb. There are other ulnar collateral ligaments. This one's of the thumb. Oh, the SI joints, are we at, we're at the lower extremity?
Yeah.
Okay, so for the lower extremity, you do all your motions, your flexion, your extension, your abduction, your adduction. And then for the SI joint, oh, the palpation. So Dr. Waldeck she has great palpation techniques. So Catherine, did we decide we're gonna have them rock the pelvis? We're gonna ask Molly if we want how much palpation.
I'm not sure what she wants palpated either.
Right, so for palpating the pelvis, I mean, you have to palpate all of the main bony prominences because you're looking for a fracture. What Catherine was saying was she had the patient, if you want to get up here, get on the table. She was having us do, you want to lay down? She was having us do a rocking motion. She was explaining that typically when if a fracture of the pelvis occurs, it usually fractures in more than one place too. So this kind of, I don't know how much Molly wants for that. We have to clarify with her how much palpating. In the past, we've just done some general palpating. To check the SI joints, when standing up, I would palpate along the SI joints, or I could have them lay prone and check the SI joints. The Faber's test is a great SI joint test. Okay, so the Faber is flexion, abduction, external rotation. It's actually what Faber spells. And so you hold on to one side and push down on the other. That checks mobility, range of motion, and if he had pain in either the hip or the SI joint. That's a good test. Sitting? Okay, that Jolie asked the same question. I would do this one lying down, and I would check both sides because typically a patient has SI arthritis on both sides. And it also is interesting, one side's always more flexible than the other, so that's interesting. I would do this one laying down, because you've got to do a lot of things laying down at this point. You're going to have to do Overs test lying down anyway. Piriformis is exactly like the sitting up. So if you did it piriformis test, you want to sit up. It's the sitting at the end. It's also the figure 4. You have him cross his legs, and you have him now hang on to your legs here and lean forward. As far as, okay, and if he had pain right in his piriformis area, that would cause the pain, okay? So that basically is almost the same test, though. It is.
When you're in inspection, when it says level of iliac crest and leg length, it says to measure
Yeah,
something.
this was our other, unless Catherine wants to jump in here. This was the other question we had. Molly is very particular about this. She has you arch the back, and that's to like stretch everything out, then relax. She also, I remember last year, she wanted us to have you like bend your knees, to have you like relax everything, and then she like to shake everything out, and she really pulls. And then what we're measuring is your malleoli. He has a little bit of discrepancy, okay, just a little bit. And so we're not actually going to measure, but we're looking for that, okay? But if you were to measure, you would measure from the ASIS down to the medial malleolus. If you were going to measure, you would pick 2 bony prominences and measure the same points, all right? But we're not having you measure.
And then on the inspection of the level of iliac crest, is that just with them standing up?
Yes, have them stand. You'll have to lift their shirt. I would really recommend that you look for them, but then feel for them. Not every patient will have really, you can't always see them, but you can pretty much always feel them. So you could really feel right here, you feel them, and then see if they're at the same place. Okay? Thank you.
And then palpation of the greater trochanter.
Okay, the greater trochanter, mine's pretty prominent. It's on most of us. It's where the widest part is near the hip joint. It's just below the hip joint, but it's the widest part. Not everybody's prominent. So it's okay if you palpate more. So run your hand down. You can have the patient help you by doing this if you need them to, but run your hand down along the hip joint and you'll get to it. I mean, it's okay if you have to feel more. It's totally fine. Like mine's all along in here. Okay.
And then the passive range of motion, just the hip flexion, internal.
Yes, so that's better lying down. So I have him lie down. I'm flexing his hip. I extend it, and then I'm externally rotating and I'm internally rotating.
And then the strength testing.
And the strength testing you could do lying down. You could do it sitting up.
And then, so we did Faber and then Ober's test.
Ober's test. So I have you turn away from me. Turn towards the group. Okay, and then. I guess we had 2 different ways we could do it. If when in doubt, you could do it both ways. I could have them bend at 30 degrees. I think it says bend. If you had it straight, it would be fine. And then I have you drop your leg.
Yeah, you're supposed to relax
Yeah,
knee within your arm, and then drop
Yeah,
it.
I don't have to hold your knee though. I can hold right here
That's true.
because I'm going to have you drop it.
Right.
Okay, go ahead and relax and drop your leg. Okay, and he's stiffer than.
My hip is
Different
digging.
different
stiff.
board.
My hip's digging into
yeah,
it.
the table.
He's in pain. But for most of you guys, your knee has dropped all the way to the table. Part of it might be because this isn't padded. I'm sorry.
Right.
Okay, but if it stays up the way his did,
Thanks,
he's got
Joe.
kind of a stiff side or Ober's IT band. Thank you.
So you have them like their leg hanging off the side of the table.
You can have it. It doesn't really. You can just all you have to do is pull it back, and then I give it room to drop. Okay. And he couldn't naturally drop it to enough, so you should do some stretches. Okay. Okay. Yeah, I'm sorry. The table is wrong. Okay.
Are you going to give me some exercise prescription after this?
Give you exercise prescriptions and massage. Good.
Right.
Good to go.
Gainsland's test. Okay, this one you do have to have him come towards me. Okay, lay down. Okay. Now, what if I have a big patient? I don't want him falling off the table. I'll just have you come towards me a little bit more, just a little bit. I don't want him off the table. I need this to drop, have enough room it could drop. And then I'm going to have you bend your knee. Could you hug your knee to your chest, please? All right. And so he's pulling down and I'm pushing this way. It works best if I could do both. I have my knee, I'm holding him up. Okay, and I'm pushing. And this is an SI joint test. Okay.
So you're just looking for any pain.
I'm looking for pain. Okay.
So you were pushing down on that.
I was pushing down. I was guarding the whole time. You don't want your patient to fall.
Okay.